Dear colleagues, really great pleasure to be here with you. Very
Hy't
welcome,
afgegaan, maar dis okay
everybody.
nou.
I'm very excited to moderate this new filmed event with a very challenging title, The Facelift with Art Fillers, Deep Dive in Anatomy and Injection Techniques. As always, a very practical meeting where you can see live dissections and live injections immediately after. And so at the end, as in all other events, if you remember, you will agree with me that live injection and facial anatomy work in parallel. You will have the possibility to ask all possible questions, writing in the chat on the screen. And after the webinar, you can also download the certificate after answering a few questions about the webinar today. But let me present you the
Écoute, moi je suis sur
scientific
l'onglet.
board.
J'ai l'impression que c'est. Ah non, c'est bon. Oui, c'est bon, ça y est, c'est parti.
The
Ouais,
scientific board
je pense qu'on est
is
OK là. Bon, voilà.
me, of course, Alessio
Voilà,
Rinaldi.
bah, écoute, je pense qu'on est bon, Elisa. Et tu vas être en copie des questions qui vont arriver.
I have somebody in the earphones. I am Alessio Rinaldi, sorry, and I work and live in Milan, and I have few years of experience in aesthetic medicine. But let me present you our anatomist, Professor Sebastian Cotofana, a good friend of mine, based in the U.S., Mayo Clinic College of Medicine and Science, Rochester, Minnesota. So, Sebastian, facelift, a very challenging title based also on many articles you published lastly on the topic, also with me in some cases, if I am not wrong.
Well, yes, of course, Alessio. We published together on this topic, and of course, thank you very much for having me for this webinar. And it is true; it's a little bit of a controversial topic, and especially if you look into the social media these days. Some people say, "What? How can you lift with fillers?" Because fillers are very soft substance, and when you think about facial lifting, you majorly think about a true thing that does a facial surgeon, like he does the lifting procedure by cutting, by repositioning, by draping certain structures. But this was a thing of the past when anatomy was not as much as evolved as it is now, because these days anatomy has evolved so much with new methodologies, with CT scanning, ultrasound, with 3D imaging. A lot of things have changed because of anatomy and because of our understanding of the face. And when the understanding has changed, the methods has changed, and of course the outcome is different. And this is why we can truly now say, with specific anatomical knowledge and specific technologies, with filler injection techniques, we can truly change the facial position towards a more higher position, which we then of course can attribute as the effect of facial lifting.
Thank you. Thank you very much. And let me present you also my good friend, Ricky Smith, based in Pretoria, South Africa, founded aesthetic medicine in South Africa, and a very expert doctor in the use of filmed range, senior filmed ambassador. Dear Ricky, are you ready then to translate the anatomical knowledge in clinical techniques that I will use tomorrow?
Yes, hello Alessio and to everyone there and Sebastian. Yes, it's exactly what Sebastian said. It's amazing how technology have changed in the products that we have and then the knowledge also that we have anatomically as well as clinically. And what we've learned, if I think of so many years ago when I started doing fillers, we were chasing shadows and wrinkles. And now it's quite different that we can actually use fillers and other techniques to lift the face. And if you asked me this 10 years ago, can you lift the face with fillers? I would have said, no, it's still, we need other types of technologies to lift the face. And what we've seen from recent publications, anatomical discoveries, and also the capacity of fillers to do tissue stimulation and collagen induction, I really think that we can get amazing results placing fillers strategically in the right place to get a lifting effect of the face. And I really hope with today, with my beautiful patient, that I'm going to show you that we can actually lift the face by following this principle of the right product, the right anatomical level, the good planning of where we're going to put it, to get that type of a lifting effect, what everybody actually desires.
Thank you, Ricky. And let me present also the agenda for today. First of all, we will have the anatomical part, as I already told you, and the assessment of the patient. And then immediately after, you will have the upper, middle, and the lower face before the dissection, and immediately after, we will have the possibility to see the injections. And so this is the meeting for today, because to get this target, in my opinion, the face lift, we really have to follow some steps and choose in my opinion, the right indication. What do you think, Sebastian? The strategy is really important and critical in choosing the right patient and the right areas.
Yes, Alessio, this is absolutely right. Choosing the right patient is fundamental for really obtaining the results that are possible. For instance, if you think about a patient sometimes comes to you in your office and says what the patient wants, what the patient truly wants. But sometimes this is different what the patient truly needs. Because sometimes the patient wants, oh, I want to look this, I want to look this way. But then you need to look at the patient and you can identify what is possible, what is not possible, what the patient truly needs, what the patient doesn't need. And I think this is very fundamental to understand what can be the desired outcome. As a physician, you always have to ask yourself when a patient presents with what the patient wants, can I do this? Can I really do this? Is it okay to do this? Does the patient require this? And sometimes it's also okay to say, no, just be honest with the patient. And especially when it comes to facial lifting and to facial repositioning, how we also call it, it's always important that our biggest adversary in all of this is gravity. And we need to understand how all of this plays together. This is why patient assessment and the right treatment strategy is really fundamental.
Yeah, and also you, Ricky, I saw your patient, and is it the lateral face so important to lift tissues clinically? Because anatomically, I saw all the articles published by Sebastian in the last 2 years, and so I have this in my mind. But clinically, always do you use this lateral technique, or there is a specific indicated best patient?
Yes, Alessio, it's quite true. It's difficult to always say if there's a specific indication, because there's some patients, when you start examining the face and using your fingers to lift a tissue, that you find they're not very good candidates. I think for this lateral lifting and upper technique, the only patients that can be tricky, not that you cannot do them, but you cannot promise severe results, is the very heavy faces, very full faces. It can be quite difficult to then see results, and there's somewhere where we don't really want to volumize too much the lateral part and try to promise lifting type of results on a very heavy face, very thick skin. So, but what I've seen in practice, really, this concept that we've presented before on the domino effect, we're not going to do exactly domino effect today, is that most patients actually have got really much better results starting from upper and lateral, and often they disagree with you because they think, okay, why do you want to actually now put fillers laterally and upper in my hairline where I don't even see it? And you really have to convince them. So it's true what you say, Sebastian, what the patient needs and what they want, we need to get to a bit of a compromise. But I still find a lot of patients are not educated of what can be achieved and what areas really needs treatment. And they would often compare with friends or somebody that's had a procedure and think that they just need exactly that. So it's a bit of a communication with a patient and showing them some results to convince them sometimes on the strategy of lateral lifting.
So, as you can imagine, from this first discussion again, an unmissable meeting where I ask you to be really very interactive, give us your questions. Our team will forward me the questions, and there is no better moment to answer when you have these experts. So back to you, Sebastian, to introduce the dissection of the face. If I have any question very tricky, I will let myself stop a moment and ask you. The stage is yours for the assessment of the face and the dissection. Thank you.
Well, thank you very much, Alessio. And I can just reinforce what my dear friend just addressed to the audience. Guys, please be interactive. Address questions to Alessio. He is more than happy to answer the questions right now. And if not, he's more than happy to do that over the weekend in the middle of the night, because this is what he agreed in the previous webinars to do.
I booked
So,
my night.
yeah, exactly. So Ricky said something very important. She already mentioned the specific principles of how we can best achieve a facial lifting or a facial repositioning with soft tissue fillers. And these principles are lateral face first, upper face first, and sometimes even the third principle, deep regions first. And I will show you now in my body donor that I pre-dissected for you here, for which we're all very grateful and thankful to be able to learn from, how these principles actually apply. So for instance, in this case, you can appreciate here the dissection that I performed. And in this dissection, the temple is already dissected. You can appreciate this here, but you can also see this line here. And this line is, of course, a dissecting line, but this line shows you something very important, because this is the line where we have the 4 most important ligaments of the face being attached from the bone to the overlying structures. And this connecting line, starting from here to here to here and down to the mandible, this is called the line of ligaments. And it's, again, it's an imaginary line that connects all the 4 most important ligaments. And this line of ligament separates the medial face from the lateral face. And now, let me reflect the respective layers to show you what is located below that line of ligaments and what is located in the medial versus the lateral face. So we're going to reflect now the skin, which I'm going to do right now here with this beautifully attached dermal sutures here. And now as we reflect this respective area, you can see how the skin is continuous from all the way up down here, moving all the way down through the midface and into the lower face. Now you might say, this is nothing new. Of course the skin is connected. Yes, the skin is connected, and the skin is connected because it's a continuous layer. And if we understand that this is a continuous layer, we can understand why sometimes subdermal procedures of the temple, which we can appreciate here in the temple, can have an effect from the upper face towards the midface and towards the lower face, because these areas are connected with each other. Now in the next step, I can reflect a different layer, and this different layer is called layer number 3. And it's called layer number 3 because it has different names. So let me expose these layers to you. So in the forehead, this so-called layer number 3 includes the frontalis muscle, which you can appreciate in this respective area here. This is the undersurface of the subfrontalis fascia, which includes the frontalis muscle. You can appreciate this here. If we move caudally towards the lateral orbital rim, we can appreciate this structure here that is continuous with the frontalis muscle. I think you can see that here very nicely. It's a continuous plane here. And this aspect here is the orbicularis oculi muscle. You can appreciate this area here. And this orbicularis oculi muscle is also connected to the frontalis muscle and is also located in layer number 3. At the lateral orbital rim, and I'm reflecting this area here slightly, you can see that there's a thickening on this area here. This thickening here is called the lateral orbital thickening and is one of the 4 ligaments that contribute to the line of ligaments in a face. If we move caudally, we can appreciate here a very strong ligament, a very, very strong ligament at the zygomatic arch, which we call the zygomatic ligament. You can appreciate this here. I can move the entire donor's head by just pulling on this ligament, and this is the strongest ligament that we have in a human face. If you move more caudally, you can appreciate here just a layer of fat. But this layer of fat is not only a layer of fat, because it includes a three-dimensional system made of connective tissue. And this three-dimensional system is called the SMAS. So that means orbicularis oculi, which is high up here, is continuous with the SMAS in the midface. Now you might ask, well, but I just see fat, Kotofana. Is there truly something that indicates that this is the SMAS? Yes, and that is this muscle here, which we know, and that is called the zygomaticus major muscle. And we know that the zygomaticus major muscle, after originating from the bone, which you can appreciate here, inserts and travels within the SMAS. And this is exactly the transition that you can appreciate here in this respective area. And if you move more caudally, following the SMAS, we can suddenly see a muscular structure here, which is located in the lower face, and this structure that is continuous with the SMAS, and you can appreciate this here, this structure is called the platysma. You can appreciate this relationship right here. So that means we have one continuous layer 3 starting from the forehead, from the temple, going all the way down into the lower face. And here in the lower face, look at this one. There is a strong adhesion here. This strong adhesion, this is the mandibular ligament. And this shows you the 4 ligaments. Mandibular ligament here, zygomatic ligament high up here, more cranial here, the lateral orbital thickening. And if we move up towards the temple, I dissected this area here, but here would be the temporal ligamentous adhesion. That's this component that I detached here, because otherwise I could have not reflected this entire flap for you. So this arrangement here of these ligaments project to the skin surface, and then this is called the line of ligaments. And this separates medial face from the lateral face. And this is why it's really important to understand those differences, because they will influence the treatment algorithm, and this will also influence how Ricky is gonna do the assessment now, and also how she is gonna treat the patient, following exactly these principles, which is gonna be great because everything is just applied anatomy.
Thank you. Thank you, Sebastian. As always, a great dissection, so clear. Seems everything so easy and so, but I know the difficulty of the dissection. And so now, dear Ricky, can you translate what Sebastian showed with us in clinical anatomy? So what we will use tomorrow. Show this in your real patient, and what is the best indicated patient for lifting procedures.
Okay, thank you, Alessio. So I think the best indication for lifting procedures is typically the patient coming to you and saying, they often mimic and they show, I want a bit of a lift and I want opening up. And when you start moving the tissue, you actually see something happening. So it's not necessarily always patients over 40 or over 50 years of age, because sometimes genetically, because of the skeletal structure, I've seen a lot of young patients with sagging, even in their 20s, because of maybe a jawline that's receded or not really good medial projection, or really a lot of loss of volume, or genetically not enough volume to support this. And those are also good candidates for lifting. So it doesn't always have to be like loose skin. But my patient, Tanya, is a very good candidate. And why I think she's a good candidate, she's beautiful. She's got a good face structure, but she's starting to show the signs of sagging of what gravity has done. And her biggest concern was specifically the eyelid. And I want you to notice, because I'm going to work on this side, but I want you to notice the asymmetry between the right and the left eyelid. And that's very typical, that most patients would complain the one eyelid is lower than the other. And often they would actually blame the doctor and say, but it's since you've been treating this or that, or maybe toxin or fillers that I've noticed it. It's often just because they're only noticing it now. But with aging, this asymmetry actually becomes worse due to many factors: how they sleep, where the sun shines the most, like where they're sitting in their car. So there are many factors worsening the asymmetry over the years. So with her specifically, she wanted to know, what can I do to actually elevate the upper eyelid a little bit. And then very typical, patients often complain about heavy eyelids, and at the same time, they're complaining about wrinkles on the forehead. Now, that's quite a tricky thing because we need the frontalis muscle to elevate the brow, but they don't like what frontalis does to the skin, because frontalis is wonderful for the brow and for the eyelid, but it's not wonderful for the wrinkles. And this is the first thing with the upper face specifically that we have to think about, that as soon as we use toxin to relax the muscle, we actually lose that lifting effect. So this is something that I would, as I get to the upper face part, that I'm really going to focus on this patient, is how can we address these wrinkles without dropping the brow? And I'm going to show you very beautifully with Art Filler Fine Lines how we can address this area to reduce the wrinkles, stimulate collagen, and with time we actually see more of a lifting effect and we don't have to relax the muscle. So this is for upper face lifting. Then also the temporal lifting that we've also described in some of the previous webinars and with the domino effect. And we know from many publications that Sebastian is part of, Claudia Hernandez has also shown very beautifully how the temporal lifting, now this is where we get to the part that Sebastian just explained, the lateral and lateral, start high, how this affects the whole face, but not only the mid face. As you will see, when we do the temporal lifting, we often see that the eyebrow also lifts. So we definitely see, and that you can see by just merely pulling a little bit. I don't know if we should maybe zoom in a little bit on the face, but we can see by just lifting the tissue a little bit here, we can actually see how the brow lifts. Just turn your head. Do you see what it does to the lateral brow? We get that lifting type of an effect. So the temporal lifting technique is really nice for giving a little bit of elevation of the lateral brow, and then I will be addressing the wrinkles there. So we will take it today through different steps of lifting. So the other lifting that patients always want is they always look in the mirror and they do this. And this is typically what women do. And they say, I look so much better this way. And where do they position their hands? Is they actually put it right on the zygomatic arch. And this is where you actually really look good in the mirror if you'd say, I just want a little bit of this. And often I get patients saying, can you just do a little bit of this? And what we've seen so many times also is with laterally, by placing fillers on the zygomatic arch and enhancing that, we see that beautiful lift effect. The other part of what we've explained with the temporal, with the domino effect, is the mandibular border and how we can enhance the mandibular angle to actually also get a bit of a lifting on the submental area as well as on the marionette folds. But there I also want to say that not all females are good candidates for mandibular or mandibular angle enhancement. Because remember, what women want is they really desire this beautiful V effect. And in Caucasian patients, they do really well often by enhancing the mandibular angle. But as soon as we get a round face or an ethnic face or an Asian patient, they really want to not have a wide mandibular width. They want a more oval or even a V effect. So in those patients, we still have the marionette folds, and you've maybe lifted here, you've lifted zygomatic, but you don't want to enhance the mandibular angle, but you want to get rid of that last little bit of fold. And that is where we sometimes need to go to the medial part of the face, so medial to the line of ligaments. Now, this is not necessarily going to give you a lifting effect as the lateral part does the really lifting effect, lateral to the line of ligaments, but it is going to play with where light and shadow falls. And it is also going to address volume loss that we find in the mid-face. And if you do this all together, and we're going to enhance the lower face where you have a lot of loss of alveolar height, you get loss of the mandibular, the bone and the structure and the quality of the bone, and sometimes also mid-face, and treating these shadows together with the lateral lifting effect, then we can really obtain a very beautiful face lifting effect. So sometimes medially is volumizing, but it gives you a lifting effect because it plays with the shadows. And that's exactly what makeup artists are doing with contouring the face, is putting highlighter strategically to actually make the face look lifted. And that also sometimes addresses the mid face where we actually do volumization. Okay, do you agree with that, Alessio or Sebastian?
Thank you.
You want to add something to this?
Thank you, Ricky, for your assessment. It was very nice. But now maybe we can go a little bit deeper in the anatomical field, starting from the upper third of the face. So can I ask you, Sebastian, to show us in the upper third of the face, which are the dangers, which is the best technique based on the anatomical, because anatomy, as always, is the basement of our treatments.
Yes. So first of all, Ricky, thank you so much for making this excellent point, because what you said is so crucial, because there are some patients who, of course, they need the facial lifting, but then the question is, what comes next? And what comes next is exactly to understand where is light and shadow and how to play with the repositioning of the soft tissues that are located in the medial aspect of the face. For instance, like you said very nicely, with the tail of the eyebrow. To understand the tail of the eyebrow, of course, we need to understand the bony fundament when we treat the forehead. And now we're going to look into Max, because Max is here with me. And I would like to show you this component here. If you look at Max from the front, you can appreciate that everything looks nice and smooth and round, as opposed to these lateral areas here, this area and the other area that you can appreciate here. But if we rotate it more and more, you can see how flat this lateral portion is. And especially if you look towards this side here, and the camera stays stable, then you can appreciate how flat this area is. And this area here is the area where we have the roof, the retroorbicularis oculi fat. And with over time, not only we lose bony substance, but also we lose fat of this area. And then when we lose the fundament, the soft tissues located here, from this position, they try to glide downwards. And this is why sometimes repositioning the eyebrows and changing the tired look in the medial aspect of the face requires deep injection, which allows the repositioning of the eyebrow. So now that we understand that aspect, it's important to see not only the soft tissues, but it's also the bone that play a factor. But how does it look like in terms of what are the danger zones when talking about the forehead and how to address this best? So for this, we're going to switch the camera and I will show you another dissection of the forehead. I will reflect the skin first. And as we reflect the skin in the immediate portion, what you can appreciate is that there are a bunch of vessels in the superficial plane. You can appreciate this here. There are a bunch of vessels located in this area, and this is why the superficial plane of the forehead is a plane where majorly toxins should be applied, but actually soft tissue fillers is not really the right plane, because from here, there's a direct and very close pathway to the branches of the ophthalmic artery. This is why the plane where soft tissue fillers can be applied and should be applied is a plane deeper, is a plane between the periosteum, which is here, and the subfrontalis fascia, which can be appreciated here. In the view from lateral, and you can appreciate this here very nicely, this would be the plane where the product is administered. This is exactly the plane. You can see we have vessels only located inside the periosteum, but there are no vessels located truly and spanning this loose area of connective tissue. So as we understand this respective relationship, we can easily understand that soft tissue fillers can be positioned in the deep plane of the forehead, and this will then, of course, affect the position of the eyebrow, because it affects the position of the frontalis muscle, which then can result in a very nice lifting effect. And again, it doesn't have to be a full face lifting effect. Elevating and repositioning the tail of the eyebrow is also a lifting effect that can be easily achieved. And I'm looking really forward to Ricky's injection technique to show us that respective area.
And so, Sebastian, here in the forehead, there is mainly a thickening more than a ligament, you know? So for the injections, it's better to stay deep. And so also about this thickening of the deep tissue, which is the best strategy?
I think the best strategy is to understand the safety concerns first. And the safety concerns first is the fact that the vessels have a direct connection to the ophthalmic artery. So that means if we understand that the vessels have a direct connection, then we might need to consider using a cannula for this area. And we also need to understand in which area would be a cannula constantly have the same plane. And that would be, of course, the deeper plane. So this is why accessing the deep plane with a cannula would be my preferred pathway, preferred technique. But I think Ricky has a great way to approach this as well.
But I know, Sebastian, that Ricky will treat also these little lines. And so probably we will see which is her approach to these lines. And we see if she can remain deep or if she needs to go a little bit more superficial to treat these lines. And so, Ricky, now, can you assess better the upper third and let us see which is your clinical approach after this anatomical knowledge that we saw with Sebastian?
So for the forehead area, there are two aspects that we can do with the forehead. We can either replace the volume, and we can replace the volume just above the brow that we often see becomes reduced with aging, and sometimes even the hollowness. So you've asked me whether I would be able to address the wrinkles in the deep level. And previously I thought no, because I thought you need to go very superficial inside the wrinkles. And I used to use the needle technique, a 30 gauge or 32 gauge needle technique, very superficially into the wrinkles to replace it. But what I've seen after treating a lot of patients in the deep plane is that we get rid of the wrinkles because the wrinkles are there because of volume loss on the forehead. We have volume loss of the bone, we have volume loss of the subcutaneous tissue, we have a loss of volume of the very thin fat pads in the forehead. So in the deep plane, we don't always see immediately how all the wrinkles disappear, but we'll assess now. But with time, we see the collagen induction, the tissue stimulation effect of what I'm going to use art filler fine lines, and you actually get rid of the wrinkles. Every month, it just looks better and better. So that is why I now, even if I'm not doing contouring, but just wrinkles, I still remain in the deep plane. It's safer, it's less bruising than the needle. The superficial needle technique. So the patients are also happy that they don't have any recovery period. Okay, so how do I address this area? Now, it's a very highly vascular area, and we still need to make a puncture point to actually get our blunt device to enter. So I'm going to use a 23 gauge, 70 millimeter blunt device to introduce art filler fine lines. I really like art filler fine lines in the forehead. It's been shown by studies also how much collagen and elastin production it stimulates. And it actually can even do contouring of the forehead. And we know that from the studies and the publication that even up to 18 months of new collagen induction is seen with art filler fine lines, specifically also in the forehead area. So I'm going to choose a point. So usually what I try and choose a point because I want to go underneath the frontalis muscle. So I ask the patient to elevate the brows. So can you just lift your brows for me? And then you can try and see where is the end of the frontalis muscle, because we know the width of the frontalis muscle really varies from patient to patient. And then I try and enter lateral to that. You can relax. And then obviously we've got some vessels here. We can actually palpate them and feel, I can feel the superficial temporal pulse here. And I obviously don't want to go right in there because then I have to find a different entry point. And I want to make sure my entry point is going to give me access to the forehead as well as this area that I want to enhance the tail of the brow to treat the wrinkles. So if I go just 1 centimeter to medial, I'm going to struggle to go through the frontalis. And also I'm going to struggle to actually treat this area that I want to treat the volume loss. So I just want to make sure again that I don't go into a blood vessel. And I'm just using a needle. This is a little device just to help you find your needle hole. And I'm going to enter with a 23 gauge blunt device. Okay, so, and then very important is then to actually go into the deep plane, as we beautifully saw on the cadaver dissection. And I'm sure also we've got the split screen now there that Sebastian can really show us the plane. And sometimes you need to really use your other hands to make sure that you're in the right plane. And I always try and tell doctors, don't use your cannula to push and find your plane. Use your other hand to make sure where your cannula is going. And I kind of lift it up and push the tissue over the cannula because it's less painful for the patient. So very important in this part. So you kind of lift it up and then progress to make sure that you go and you actually kind of feel a click. And now I know I'm in the deep plane. And how I know that is if I lift up the cannula, I don't see the complete outline of the cannula. But remember, we're in a plane, or we're in an area of the face where the skin is paper thin, the frontalis muscle is paper thin, even the fat pads, especially in this patient, is really paper thin and almost non-existing. So we are going to see a little bit of the cannula, but I can really feel that I'm in the deep plane. And then what I try and do is start from the medial part and then go lateral, because this is usually the worst part for the patient. And if they have a lot of indentation above the superciliary arch, you can actually add some extra product. Okay, I'm just going to ask her to elevate the brows again, just to make sure you can visualize exactly where are all the wrinkles and what is the area that we need to cover to get rid of the wrinkles. Okay, you can relax. Okay, so sometimes if the patient experiences a bit of pain, the best is just to inject a little bit of product. Okay, and that would just also give a bit of relief. So what I'm doing now is my device got this little red dot actually pointing where the product will exit, so the opening. So I'm going to turn it down so that I make sure it goes into the deep plane. And that also reduces the lumpiness that we get. Okay, so the medial part is the worst. Are you okay? It's not too painful? She looks quite calm. Usually it's quite easy to see. And also the other reason why I prefer art filler fine lines in this area is because it's such a nice soft product, so easy to mold. We can see it's a little bit of a bolus that I made. You just push on it and it's so easy to massage because I don't want to walk out of your practice with lumps and bumps. And then I do a type of a fanning technique. And this you tailor make according to where the most wrinkles is or the most volume loss is. So some patients have got only wrinkles here, so you're not going to treat this really frontal bossing area. And other patients have got a lot of wrinkles here, you're going to address that. So she's got a little bit overall, so I'm going to fan this whole region.
Ricky, I have a question.
Yes.
Yes. You are showing us the 23 gauge cannula. Do you use also the 22 gauge cannula? And also another little question, how you make different the technique for the contouring for fine wrinkles, okay? And how do you change if you get a contouring and you want to make some volume more?
Okay, so first of all, with the 23 gauge, you can definitely use a 22 gauge. We obviously know that 22 gauge is even safer, so even more difficult to penetrate a blood vessel and cause a hematoma or go intravascularly. But the 23 gauge used very softly and mildly and not doing, I always say, like liposuction movements, is a very safe tool and very easy to use. So what I usually do a little bit different for contouring versus wrinkles. So if they really have volume loss, I try to always make sure that I place my filler very deep and I make sure that the cannula is pointing downwards on the bone. And if I really want to address a little bit more wrinkles like this area, I actually turn it up so that the product goes slightly more upwards, like I say, not really superficial, but because superficial, I would need to be in the dermis, but just to get a little bit more closer to the dermis and get that area. But what also changes is your product. So if they really have got volume loss, I would often go for universal. And if it's more like this patient that doesn't have a lot of volume loss, but more wrinkles, then I would go for fine line. So the product also makes a big difference. Okay,
how you can avoid the vessels in this area that I see here? There is also a vein with the blunt device, of course, is much better than the needle. So you use it normally, or you use also the normal needle?
So if I use a normal needle, especially in this area, I'll make sure that I go deep onto the bone, aspirate, and then inject. So now I'm exactly there at the tail of the brow that we want to do a little bit of enhancement of the tail of the brow. This is an area that often I know many doctors just inject right there with a needle, very deep on the bone, aspirate, and make sure that you're not in a blood vessel. But even with your blunt device, make sure that you respect the blood vessels. There's blood vessels here that we can see very clearly. So go very softly so that they slide out of their way, and don't try and puncture them. So you can really imagine for yourself, if you're going to force the cannula, you will be able to puncture the blood vessel. So it's all about being gentle.
Any
trick,
any suggestion, Sebastian, for the injection in this area? I see your specimen, and so any tips or tricks that you can give us?
I think Ricky is doing a fantastic job because she does a lot of things right. For instance, she approaches the vessels in a perpendicular approach. And by a perpendicular approach, and I'm showing you this here, as the vessel is a very small one between the branches of my forceps, it's really a perpendicular approach. So that means the contact area is small, as opposed to coming from the top area here, where you have a very long contact area between the tip of the injection device and the vessel. You can see this here. This is why approaching from lateral is always of greater benefit for the patient in terms of safety. The other aspect is using a blunt tip device. And you can see that here, the blunt tip here has really substantial difficulties to enter into that vessel. It actually always glides on the side. You can see this here. I'm trying to mimic this area here. It's just glides on the side. As opposed to if I would use a needle, that would look a little bit different. Because if I would have a sharp tip needle, and I will mimic this to you again here, with a sharp tip needle, the vessel has no chance to move out of the way. You can see this here. The vessel has no chance to move out of the way, and I can easily puncture that respective vessel. And you can imagine puncturing those vessels here in this respective area is the thing that we don't want to have, because from here to the ophthalmic artery is really a not very far distance.
Ricky, I have a question. Can you explain in vivo why you choose the rheology of our filler fine lines in this indication?
Okay, so the reason why I choose art filler fine lines is not only because it's published and scientifically shown to be a very good product, but because this area, especially in a patient with volume loss and thin skin, it tends to show the filler that you've placed. So a very soft, very moldable product that you can shape very easily, doesn't leave those lumps and bumps that take sometimes a few days to settle. So we can actually see on this patient a very nice smooth appearance. Just lift up your brows for me, and you can already see what effect it's done on the wrinkles, because it's replaced the volume and we don't have that loss of volume that the skin has to pull over. So really a very good product, and also because specifically it contains also a lot of free hyaluronic acid, and the not the very long chains of hyaluronic acid. We know that it's also going to give a lot of tissue induction, so meaning more collagen, more elastin, that we want for that lifting effect of the brow, which we don't always see immediately, but from 6 weeks onwards, you start seeing new collagenesis, and you really see that lifting effect on the forehead. as opposed to botulinum toxin that's going to be placed in the frontalis and going to drop the brow. This is actually over time going to give you a lifting effect. So it's almost like an investment that I tell my patients every year we need to do this, because for the next year, you're not going to lose collagen in the skin here, but you're actually going to gain collagen. So a very good investment. So a good way to tell the patient is that it's an investment of your forehead, and you're probably going to need less toxin if you're then going to do toxin.
And in average, how much product are filler fine lines do you use in the forehead?
So in the forehead, I always try to use at least 1 milliliter, so 0.5, 0.5. Sometimes if there's really very deep indentation, you need to add a little bit. But on average, on most patients, I use the full vial of Art Filler Fine Lines, 1 milliliter, to cover the full forehead area.
There is a little question. A doctor asks me, the injection is subdermal. I guess that you were a little bit deeper. Can you explain better?
Yes, maybe, I don't know if we can quickly go to Sebastian's cadaver image to show, because he was showing also the level and where I was with the cannula. So it's underneath the frontalis muscle. So it's a deep injection. It's not a subdermal. Subdermal, you can probably do with a needle. It's more tricky on the forehead with a cannula if you really force it, but it's very painful to go in the subdermal level with a cannula, especially on the forehead. Okay, there we can see very nicely. So Sebastian is showing on the cadaver there.
So the exact level of this blunt device is lower. Sebastian.
Yes, it's really on the bone. Yeah, Sebastian can explain.
So it's absolutely right. So the plane of the blunt tip device is the supraperiosteal plane between the subfrontalis fascia, which you can see here, and the periosteum. The reason why the subdermal plane with a cannula is so tricky is because in that respective plane, we do have a fascia on top of the frontalis muscle, which allows the frontalis muscle to connect to the overlying skin. And because of this intimate connection, this is why we can see immediately wrinkles on a skin surface as soon as the muscle contracts. Because in no other area of the face, we do have this intimate and direct connection between muscle action and then skin wrinkling. And of course, it makes total sense if we change the fundament of this entire area, if we stretch the overlying frontalis muscle, of course, we have less wrinkles of that respective area. And even if the product contained a little bit of local anesthetics during this procedure, and we have a little bit of numbing of the frontalis muscle, you can see the difference in the contraction pattern between the treated and the untreated side. I think maybe Ricky can show us this. If the patient tries to raise the forehead, you can see this right away in the difference of wrinkle appearance.
Yeah, maybe we can quickly show the patient. Can you elevate your brows? And do you see already the difference that we see in the two sides on the wrinkles? I hope it's nice and clear on the camera. Can you see it nicely?
Yeah. Very good.
Yeah, we can see it.
Yes. Yes.
And Ricky, I have another question. Do you have in your experience maybe the possibility of migration and that the product can go down? And I would like also from Sebastian some explanation on the use on the injection of this filler down to be safe and not to avoid maybe the accumulation of the product. Ricky.
So Alessio, you said a very important point, which is product migration. In the forehead, because the product is being applied into the loose connective tissue, the product has sometimes the ability to glide craniocaudal. Sometimes you can see some streaks in a vertical orientation, but with a little bit of massaging, this product can be immediately distributed. The other aspect is, can the product migrate towards the inside of the orbit via the pathway of the supraorbital or supratrochlear canal? The answer is it's very, very, very rare. I'm aware of only one case where this was possible. And in this case, it was only possible because the patient who was treated for the forehead had the next day spinal surgery. And then the patient was lying for 6 hours with face down in a ring. And this applied so much pressure that pushed the product from the forehead into the orbit. And of course, that caused a little bit of troubles, but this is a very rare case. And to the best of my knowledge, it's only the one and only case that I'm aware of this, because otherwise the product will stay exactly where it is in the forehead.
Another question that I have for the upper part of the face. How do you treat the eyebrow and also the temples that now you didn't treat until now? Which is your strategy, Ricky?
Yes, I was actually hoping that we can maybe steal some time from the mid-face and ask Sebastian just to quickly show the temples, because I would like to show the temporal lifting, because I think that also really impacts the mid-face. So I would really like to show the effect of it, but maybe we should start with Sebastian showing the anatomy, and then I will do the temporal lifting.
Yeah, Ricky, of course. And I think together with what Alessio just said is to focus on the connecting areas from the forehead to the temple and address the next step of the lifting features or of techniques that can induce lifting. And the temporal lifting technique, which was first published by Claudia Hernandez, is actually one of the strongest techniques with soft tissue fillers that can induce a facial repositioning effect. And the reason why this technique works so well is because it is a bolus technique, which does not include fanning, because with every fanning procedure, you disrupt retinacular cutis and septae. But with this technique, you preserve all of them because you need them. You need the support of the septa and of the ligaments throughout the entire face. And the other aspect is the product is being positioned subdermally. And for subdermal, this is a very important aspect for safety. And I will show you now the respective features of the temple as it relates to the safety aspects and, of course, to this respective technique. So I made this incision, this square-like incision that you can appreciate here, and I'm reflecting now the skin. And as I'm reflecting the skin, you can immediately appreciate the superficial fatty layer. And as you can appreciate the superficial fatty layer, I think you can follow me in a way that you see there's no major vessel included here. No major vessel can be found in this plane. And this is the plane where the product will be administered for the temporal lifting technique, which Ricky is going to show you in a bit. But the question is, where's the artery? Well, the artery is in a plane deeper. And here you can see the artery. This is here the anterior branch, and the camera can go now a little bit in greater detail. Here you can see the anterior branch, and here you can see the posterior branch as they emerge from the superficial temporal artery, which is the most cranial branch of the external carotid artery. You can appreciate those branches right here. But all of this is found inside the fascia. So that means from the safety aspects, this plane here, if I'm able to reflect it here again, this plane here is a safer plane because all of the vessels are located in a deeper plane, right? And if we go a little bit more caudally, we might find also another smaller vessels, which we call the zygomatic orbital artery. And if we move deeper into the forehead, then we can also appreciate the deeper layers of the temple because all of them are connected. Like the frontalis muscle is connected to the superficial temporal fascia, is the periosteum with the deep temporal fascia, which you can appreciate here. This here is the deep temporal fascia. And as I'm reflecting the deep temporal fascia, of course, you can appreciate temporalis muscle, and deep down there, the deep temporal fat pad, which is actually the buccal fat pad of Bichat. And deep to this one, we have some other vessels like the anterior deep temporal artery, which is here, and the posterior deep temporal artery, which is hiding here inside the muscle. It is important to understand that the deeper you move in terms of layers into the temple, the less effects you have for the mid-face and for the lower face. That means with the deep injection technique for the temple, only regional effects can be expected. But with subdermal injection techniques, like Ricky is going to show us right now, then we can have panfacial effects which extend from the temple down into the midface and even down into the lower face. Why? Because the layers are connected and we utilize the bolus injection technique to leverage on the retinacular cutis. And I think with this, we have understood the underlying anatomy of the temple. And now I'm really looking forward for Ricky to show us the temporal lifting technique.
Wonderful. So I guess that now you will inject the temporal part. Ricky, to you. Let us understand.
Yes. Yes, so basically now I want to be in the subdermal level. I don't want to be deep. I don't want to be close to the arteries, and I definitely don't want to be into the temporal muscle, because then the patient will really jump on the table. So the trick is really to get to the subdermal and to be superficial, because the superficial layer, as Sebastian explains, is the layer that's really connected to the mid and the lower face, that's going to give us this repositioning of the tissue. So there are different points to enter. I think it's important what length of cannula you're going to, or blunt device or needle you're going to use. So I usually go just underneath the zygomatic arch, and then I really want to make sure that I'm in the superficial plane. So what I want to, if your blunt device doesn't show where's the opening, you need to maybe just mark it or make sure where's the opening, because you want to be superficial. And then how you progress with it is really important. So I try and lift up the tissue to feel exactly where I am. In a superficial plane, not always the easiest plane. Deeper planes are sometimes easier to find. Obviously, the temporalis muscle, you'll know immediately when you're in it, as the patient will feel. But you need to see the outline of the cannula, and you need to at all times know that you are subdermal.
I don't know, Ricky, if we are looking at your screen, maybe can we see anatomically where is exactly the blunt device that is using Ricky while Ricky tries to get connected in a better way. Sebastian.
So Alessio, thank you very much. And I will show you and demonstrate this on my patient until Ricky has reestablished the internet connection.
Yeah.
So what is important about this technique is bevel has to be up. And if the camera can focus closer on this aspect, I think everybody can appreciate that the bevel is high up here. There we go. There is the bevel, and the bevel needs to be in bevel up position. And as the bevel is in up position, it's pointing towards the skin. And the dermal axis is from the tragus, as you can appreciate here, 1 centimeter anterior. And I can see that Ricky is back with us. And so this is exactly the dermal axis point from tragus 1 centimeter anteriorly. Ricky, beautifully. I'm just mimicking and explaining what you have done so far.
Yes, so as you can see, I'm in the superficial plane, just as Sebastian explained nicely, just from the trachea upwards. And I've started already with my bolus of product to place it. It's really in the hairline. So the only problem is sometimes patients with very short hair that cannot tolerate the bolus. But as Sebastian also explained, is that we don't really want to disrupt the tissue and do a fanning technique, but we want to do a bolus technique. So you need to watch your patient very carefully, make sure that they don't experience any pain or discomfort. And you want to make sure at all time, where is your cannula? And then you can put your bolus of product. Now, we know from putting 1.2 milliliters of arch filler volume, we create a very big bolus that is palpable for the patient, but we get an amazing lifting technique. In some patients that really don't want to feel it, I go for less product, 0.8 or 0.6. but to get the really very good lifting effect, a whole vial of the art filler volume is going to give you that tissue repositioning.
So
I don't
just
know about
to
you, Alessio,
underline,
how much product?
Ricky, you are injecting in the subcutaneous tissue with the blunt device, and you are strictly subcutaneously, and you inject a bolus of product exactly in the place that we see, right?
Yes, correct. And the subdermal and a bolus exactly there that can be felt by the patient. But really, especially with her having long hair, they do not see it, and there's no problem for the patient. If we have time, we can maybe just let us sit up quickly to see what effect it has done before we move to the other parts.
I see also a lifting of the eyebrow, but this is for all the treatment you did. I see this. And
yes,
also
it's a
the
very nice
nasolabial fold.
lifting.
Yeah.
Yes, because if you remember in the beginning, I told you that this side, the brow was actually lower and the eyelid was heavier. And now we actually can see that there's definitely a lifting, despite the fact that this was actually her bad side of her upper face.
Very great results. I really like it. You can see it right away. Great.
It is immediate and then improves by time or remains stable. And because I use a lot of this technique from 6 months, that passing the months, the result gets better. Is it also your experience?
Yes, and I think it really makes sense that the result gets better over time. Because the product and the unique rheology of the product and the tissue induction that we've seen from studies can clinically be seen by the patients, that after 2 months, they actually see more lifting because we've stimulated collagen. And the patients really come back and they say they initially thought they saw a result, and 2-3 months later they say they really now see even better results. So even the patients see it. And I've done a few patients also that you can really very beautifully see it with a Vectra device that shows you the volume differences. With time, you can actually see that improvement because of the properties of art filler volume and the rheology that's so unique to give us this tissue induction and not only filling.
Sebastian, a little question I have for you to close and then we move on. Is it possible that injecting here with a blunt device, some filler can come back along the device? I know that you did some studies that confirmed this, and so is it better to put a finger here to avoid this, or it is useless?
No, Alessio, this is a very great question. The answer is yes. When the blunt tip device, as you can see this here, as this is being inserted into the tissue, it does not cut the tissue, it ruptures the tissue. And while it does that, it creates a canal. And this canal allows for 60%, around 60%, more uncontrolled product spread than it does with a needle. Because a needle, it cuts through the tissue, and this allows for the creation of a very thin injection canal. But with a blunt device, it ruptures the tissue, and then the created injection canal is by 60% larger. This is why when you perform this injection technique, what needs to be done is that the finger of the non-dominant hand covers and compresses the injection canal so that the product cannot migrate retrograde along that created canal. And one of the things that I would really like to show to the audience, and I would like to ask Ricky to show to the audience, is actually the effects on the jawline and on the marionette line following the temporal lifting technique? Because we looked at the mid-face, we looked at the changes of the eyebrow, but I'm really curious how the immediate effect of this treatment on the patient looks on the jawline contouring, and on the marionette line, because this is where we have the strength of this technique. And Ricky, maybe you can show us this again before we move into the next segment.
You can see, can we maybe just zoom on the patient's face? So what we can really see very beautiful here, if we compare the two sides, is how the mouth corner has actually lifted already. The marionette fold already looks better. So now we actually need less here. So what concerned me when I saw the patient was the shadow that you can actually see here in the lower perioral region due to the loss of the bony resorption, loss of alveolar height. And it actually already looks better this side, and I haven't touched it. And even on the jawline, we can already see the nice oval and the straight line on the jawline.
Ricky, can you show us please the side view of the patient? Thank you. The side view and the mandibular angle, so we can see the view. Yes, that would be perfect. Of both sides, yes.
Okay, can you see it here? Okay, so here we can see the jawline and the marionette fold. That's improved. And then let's turn to the other side. Okay, just like this. Okay, and here we can actually still, let me just position. We can actually see this side, the marionette fold is still, there's still a little bit of laxness and looseness here. And we actually see the indentation more clearer. And although I didn't touch anything on the other side, as I explained, we can still see it on this side.
We really see in a very good way. Just to summarize and pass to the next area. So only one bolus. I have a doctor that asks me to clarify a bit. Only one bolus in the subcutaneous tissue. How much product? I would say, I don't know if you agree with me, Ricky, from 0.6 to 1.2 ml, from half a vial to one full vial. Exactly in the same bolus. And if you see that some product comes back on the blunt device, put a finger and put it very close. Do you agree with me, Ricky?
Yes, I completely agree with you, Alessio. Between 0.6 and 1.2, obviously 1.2 is going to give you the most tissue repositioning, and that is why we see such a beautiful result. And the product is really not visible on this patient.
Totally not visible.
I don't know if you can see, not at all visible. Palpable, but not visible.
Thank you. Thank you both. And we can move on to the next area, mid-face. And as before, Sebastian will start with the dissection, and immediately after we will see the injections by Ricky.
So let's move into the mid face, because following the regular treatment algorithm of the upper face first, we covered the forehead and we covered the temple. And of course, the topic of this webinar today is facial lifting. And now you might ask yourself, but how can we do facial lifting if we treated the forehead? Well, of course, we cannot influence the mid face and the lower face because the eye is in between or the mouth is in between. But the forehead is important to expand the lifting techniques. And the lifting techniques that we just presented to you was, of course, the temporal lifting technique for the temple, which influences the middle face and the lower face. And you could have seen that very nicely, that even the jawline was improved despite we injected in the temple, which is totally off, far away from it, but because the layers are connected with each other. This is why we see the respective effect in a totally other area than we treated initially. So the next segment after and following the principle of upper face first and after we treated the temple, of course, is the mid face. And in the mid face, there are two aspects that need to consider. One is the lateral midface. The other one is, of course, the medial midface. In the lateral midface, there we don't have a lot of structures located. Majorly masseter muscle, parotid gland. Otherwise, we do have a small tiny little artery, which we call the transverse facial artery. But the major aspect what patients look at is, of course, in the medial midface. And if we go to the overview, I would like to show you where this area looks like. The here in this respective area, this would be the medial midface, and that will be the area which Ricky will address in a bit. And here in this area here, there we have a lot of mobility going on. A lot of mobility is happening in this respective area because there are a lot of muscles in this area. Laterally here, we have no facial muscles, but medially, we do have facial muscles. This is why we have substantially a lot of active mobility. But in this area here, where we don't have facial muscles, this area is affected by the effects of gravity. And those effects of gravity here result in an increased passive mobility. And passive mobility means nothing else than this area here, and this stripe going downwards towards the lower face is affected by the influences of facial aging and by the effects of gravity. But if we move to the medial aspect here, I reflected the skin, as you can appreciate in this area here, and immediately I was able to expose the superficial fatty layer. And this superficial fatty layer that you can appreciate here has increased mobility. This layer here moves substantially more than a deep layer. And I will show you this why, because this layer here is lying on top on a muscular plane. For instance, medially, we have here this muscle, which we call the levator labii superioris alequenasi. By the way, this is the longest name for a muscle in the human body, just for this tiny little fellow here. And then laterally, if we move towards the lateral aspects, and I will rotate this area for you for a better appreciation. You can see that here very nicely. Laterally, you can appreciate this here from the lateral view, that in this area here, there is deep fat. This fat here is called the SUV, and you can imagine this area here moves a lot, whereas this area here doesn't move a lot. The reason is attached to the bone, and it's located between two ligaments. For instance, here, one ligament that you can appreciate here, this is called the zygomaticocutaneous ligament. The other ligament up here, this is called the orbicularis retaining ligament. And if finally we would find the canal with the camera at some point, I could also show you the extent of the SUV, which we can appreciate here. This is the area where my forceps is now gliding in, and you can see that on the surface right here. This is why the deep area does not move a lot, whereas the superficial area does move a lot. And this is why the principle of, actually the third principle of facial aesthetics was designed, that deep injections first. Deep injection first does recreate the bony fundament, does not influence the natural facial mobility. And of course, the deep plane is a majorly safer area for injections, because even if you now might think, yes, but we do have the transverse facial artery, like this artery here, or we also have the infraorbital artery, which we have in this respective area here, as it emerges from the infraorbital foramen. You can appreciate that area here, and I will show you this foramen in a bit in a greater detail. These arteries here are branches of the external carotid artery. And these branches have no immediate and direct connection to the ophthalmic artery circulation, because they emerge from the maxillary artery or from the external carotid artery. And you can appreciate this, that the deep plane is a majorly safer area than the superficial plane. But the question is, why is the superficial plane a little bit more dangerous? The reason is, in this area, we do have a vessel, which we call the angular artery. You can appreciate this artery here. And this angular artery from here travels all the way up here, here, and at some point connects to branches of the ophthalmic artery. This is why the deep injection approach is preferred. And now I would like to show you a close-up view of the infraorbital foramen to demonstrate you that this infraorbital foramen does have only a artery and a nerve, but it does not have a vein. So this is the camera that I have here. We can go in a very close-up view, and I'm moving closer and closer to this respective area. And you can see this from this view here, that in this area, you see no vein. You just see here the artery and the nerve. And if the other camera could show the overview, that would be fantastic to see where the scope is going. There we go. This is the scope that I'm using. And if we switch back to the scope, you can appreciate that exactly here, this is the infraorbit foramen that we're looking at with the respective branches that emerge from the external carotid artery and from the maxillary artery. No direct branches here emerging.
Can you improve just a moment the focus on this area from the lower camera that was so nice?
Well, Alessio, this beautiful scope camera here, this has an autofocus. So that means I cannot influence it. It just has an autofocus. I'm very sorry for this one, but I think everybody could see it. But maybe Eric can do some magic with his camera, because Eric actually never likes when I use the scope because it has an autofocus exactly for the reasons that you have. And we're going to try this again with Eric's magic. And now this is Eric here in this camera view.
Now is much better. Thank you so much.
Now you boosted Eric's ego into the universe. I totally see that. So here you can appreciate the infraorbital foramen with the respective artery and the nerve as they emerge from the infraorbital aspect here. And in terms of the location on the skull, we are exactly in this position here where my finger is pointing at. This is exactly the point. One important aspect that I would like to bring to your attention is if we use a cannula, the approach towards the midface should always be from lateral to medial, always lateral to medial, because never the other way around, or even from top to down, because if there is any interest of coming from inferior to approaching the infraorbital foramen, you can see that the foramen here has a hood, has really like a protecting bony rim. Advancing with the cannula from inferior allows us to exactly pierce into that orbi rim, and then from here, there's a pathway into the orbit. So we need to be very careful in which direction we advance with the cannula, because this is exactly what we do not want to have, because this is just the anatomy because of this bony orbital rim that we have here in this respective area.
And
so I hope with this...
And so, Sebastian, a little question. If you use the blood device, which is the best entry point translated on the human face, where do you choose exactly the point, the entry point?
Alessio, this is a great question. And I think if you ask 2 or 3 different injectors, you will have 10 or 15 different opinions. Because everybody has its own way of assessing, own way of drawing, own way finding a dermal axis, but and of course I also have my own opinion, but I would like to show you how I always measure and how I always find my dermal axis point. And you might say that's pretty easy, but yeah, this is how anatomists think, right? Doing in an easy way. So if you go to the overhead camera, what I always trying to understand is where is the area where my product needs to reach. For example, I'll just use example the tear trough. If my product should be located in this respective area, I'm choosing the tip of my cannula because there should be the product, and then I'm measuring the way backwards, okay? This is a 22 gauge cannula, but if I would have a 25 gauge cannula, which I'm doing right now, I'm just positioning the tip of my 25 gauge cannula here, and I'm measuring backwards. So it means my dermal axis point needs to be here, exactly in this position. Because if I'm choosing a dermal axis point that's further away, I will never reach over there. So the same thing with other locations. I'm just trying to estimate where I want my product to be, and then I'm choosing the dermal axis point. But of course, there are multiple other ways to do those aspects, and I'm sure that Ricky has some great tips and tricks for this.
Back to you, Ricky. So let us see your injections.
Okay, so I didn't really like so much to see what Sebastian was doing with the blunt tip device or the cannula, so I decided to go with the needle technique. And I must say in the mid-face, I often prefer the needle technique, respecting that you have to always make sure that you're not intravascular. And what we want to achieve in the mid-face region can be anything from nasolabial filling to medial cheek fat pad to lateral. And I always like to blend it. Always make sure that the patient doesn't already have existing malar edemas, as we can see slightly in this patient. So I would want to avoid this region. And then obviously you always want to avoid filling up the nasolabial fat pad. So, and also I don't want to enhance the fullness of the medial face without also addressing the lateral part to get a bit of a lifting effect. So I like to use a two-point technique on the zygomatic arch lateral and then more medial to support this area that often gets rid of the tear trough without actually touching the tear trough region. And for this, I'm going to use the needle. So laterally, starting on the zygomatic arch, I want to go lateral to the zygomatic cutaneous ligament. You can ask the patient to smile. Can you smile big? And then often we can see a little bit of dimples. If you like, you can see the dimples. And that gives quite a good indication of where the ligament is. And you want to be lateral to this ligament to get a nice lifting technique. You can relax. And then I want to be deep on the bone, but I don't want to scratch the bone with a needle. So I lift up the tissues and then make sure that you are deep in, but not scratching. And then always the aspiration test is very important. I'm using volume because I really want to get good projection laterally. And that already has an effect on the medial part. And then often we need less product there. How much do you need here? It really depends from patient to patient because you need to evaluate how good projection do they have on the zygomatic arch? What is their mandibular width? What is their facial structure? So it's always difficult to give a recipe because it really varies from patient to patient. And that's something that you have to get used to, is to plan the amount of milliliters. So on her, I'm going to use 0.5 milliliters, and then you can always reevaluate. And we can see quite a big bolus that I've just created here. But what you will see, the product is very nice and easy to massage. And I think maybe that is why they call it art filler, because it really makes you an artist, and very nice to mold. So you don't always have to do everything with your needle, because especially with a needle, you want to make sure you're not in a blood vessel, and then don't move the needle around, because it doesn't help. You go in, move around, and then you've already aspirated, because then it doesn't mean that you're still there where you want to be. And then I'm going more medial to really address the shadow underneath the eye and to give a little bit of medial projection, because that gives a very nice youthful face, because we often see in children the nice fullness here, and it enhances in women especially that beautiful OG curve that you see on a three-quarter view. Now this, we are really in the danger zone area. So we know it's a more vascular plane, the medial, more vascular, the medial part of the face. We are close to the foramen, and we saw that really beautiful artery on the cadaver dissection. So aspiration is so much more important here. So usually what I do for this region is to lift up the tissues.
Can you
go
move
in perpendicular.
little...
Sorry, I'm a bit in front of the camera. Can we maybe move the camera?
Oh, and now we see in a very good way. Perfect.
Okay, it's better. You can see. Is it good now? You can see, or is my hand still?
Yeah, perfectly.
Okay. So yes, you can ask.
And
so now I'm doing aspiration, just to make sure. And then I'm going to inject a bolus without moving my needle. And at the same time, you are watching the circulation of the skin, you're watching the patient, and making sure that your needle has not maybe moved. And this is quite important. And for this area, can be anything from 0.3 to 0.5 milliliters needed. She doesn't need too much. And then we can see the bolus and then massage it very nicely.
Can I ask Sebastian to show maybe which is the danger in the area and how to avoid it with the aspiration test. It is enough, or we need some other tips or tricks?
So one of the most important aspects to understand of this area is that a deep area where Ricky is injecting is a majorly safer area, because deep in contact with the bone, no major vessels can be found. The zygomaticofacial artery is a little bit higher up, which means it's out of the respective area. The transverse facial artery is a little bit more lateral, as you can appreciate here, and the infraorbital artery is here, and the angular artery is also high up here. So this area where Ricky is injecting right below the zygomaticocutaneous ligament to reposition that area very nicely is a major safer area. But it doesn't mean that there are zero vessels, because zero vessels would not be good. And you know this very well, Alessio, from your clinical experience as a master surgeon. You know this very well, that everywhere in the face we have vessels, which is a good thing. This is why aspirating is always great, but aspirating has also its caveats. It doesn't mean that when you are negative, you are 100% safe. It doesn't mean that, because there are a lot of different factors that influence positive blood aspiration. But it's always good to perform this procedure because, and I can promise you, if you don't perform pre-injection aspiration, you will not see blood in the needle hub, irrespectively if you're in a vessel or not. You just need to perform this exercise because it will give you a certain degree of freedom, and especially those of the audience, whoever has aspirated blood, I'm sure you agree with me, you're very happy that you did it because you saw it that you were in a vessel.
Is it possible a migration? I know that also here with the needle, you did some studies, a migration of the product along the needle, and so inject the malar superficial fat that, as in my opinion, is not indicated. Much better to inject deeper.
Yes, Alessio, you're right. I mean, you're right. Injecting with a needle will allow the product to migrate into more superficial layers. And if we inject into a deep fat compartment, the product should stay there, but with a needle, it does not. But in a mid-phase, this is a different approach. And I will show you this now in this little experiment that I would like to provide to you. Is I'm injecting in contact with the bone, and you can see that here that my needle is in contact with the bone. And if the camera can go a little bit closer, you can see that I'm really in contact with the bone. And what I'm doing now is I'm injecting product into that respective area. And you can see that the product distributes in a deeper plane, which is very nice. But you will also see that at some point, the product will also show up in more superficial planes, which means within the superficial fatty layer. And the product, as it is now also in a superficial fatty layer, you were able to see it a little bit here coming out, and you can see it here in a superficial fatty layer, influences the mobility of the malar fat pad, as you said very correctly. But this mobility here is still possible because we have a lot of muscles. But what is more important is the aesthetic outcome, because in the area where Ricky injected, we have a very high surface volume coefficient. So that means the effect of the product is very great and very good visible on the skin surface. And it's even better with a needle because we'll have more projection effects of this area, because the product will migrate along the created canal and it will really form like a layer and layer on top of each other. And then the product and the rheological properties of the product will add on to give you a very nice projection effect. And this projection effect can be seen majorly with a needle and are beneficial, much more beneficial with a sharp tip needle than with a blunt device.
Ricky, a question. When you prefer to use, which is the best indication, you use the blunt device, and when instead, as in this case, and I would like to appreciate the immediate result in the meaning in the mid-time, when you use instead the needle and deep bolus technique, different indication.
I think it's really what you want to achieve and which other technique you also want to do. If I want to do just like I did the lateral and the medial. The needle is very easy, very safe. If you're in the right plane, you aspirate, make sure. But if I want to do a little bit of this medial enhancement and at the same time also place a little bit of product tear trough, I will then obviously go for the blunt tip device, as Sebastian actually showed you the plane, and then I would go more superficial and place a bit. Sometimes you also want to go for the blunt tip device to move maybe nasolabial. So it's more got to do with what else I want to do at the same time, whether I use the needle, the sharp needle, or the blunt needle device. And then the other factor that can also affect it is older patients that very easily bruise. I will go for the blunt tip device instead of the sharp needle. And especially if they're using medications that will give them more bleeding tendency, then I would also rather than prefer for the blunt tip device instead of the sharp needle.
Thank you. Thank you. So to summarize, we used until now for the forehead superficially are filler fine lines. For the temples, you confirm me temporal lift. You used are filler volume, and now for malar area again are filler volume. Is it right?
Yes, that's correct.
Wonderful.
Yes, so it was the fine lines. Yes.
I have another question for both. We inject laterally to the zygomatic ligament to get the lifting, but you injected also medially. So which is the best patient for lifting and the best patient for volumization?
Okay, I will maybe quickly explain and then Sebastian can explain the anatomical point. And I think the best is both. If I want to do volumization medially, I like to start laterally. And by starting laterally, either temporal or zygomatic, you actually see the tissue lifting and you need less medially for volumization. And this is exactly what Sebastian explained, the line of ligaments. So I would always start, but even if I plan to only do medial, I like to always add a little bit laterally. It gives a better curve and we also get a lifting, and everybody always wants lifting. So that's from a clinical point.
Sebastian, anatomical point.
I agree with Ricky because just focusing on one side, especially in the mid face, is immediately visible. So just staying in the mid face, just lateral to line of ligaments will not do the aesthetic outcome that we desire. This is why going also medially will support. But here comes the other aspect into, which is called, and I mentioned this before, is the surface volume coefficient. The area where Ricky injected, and which is the malar area, the upper medial mid face, has a very high surface volume coefficient. And because having such a high surface volume coefficient, it allows for a lot of surface projection, but also with immediate repositioning of the midfacial soft tissues. Now you might ask, how is it possible that in the medial face you get a little bit of lifting? Well, the answer is because exactly in that area you have ligaments. And those ligaments can be repositioned by the soft tissue filler. And I would like to show you how this looks like, because sometimes it's a little bit difficult to understand. And if I ask Eric again to get ready with his wonderful camera, which seems to be much better than the scope that I always prefer, I would like to show you this relationship here. I'm going to reflect again and show you the respective layers of this area, because it's a very simple thing to understand. So here, this here, zygomatic cutaneous, here orbicularis retaining. During the process of aging, these ligaments from a 90 degrees angle, they transition into a 45 or even to a lesser angle. So you can see that from this location into this location. Can you see the change in the angle from here to here?
Yeah, perfectly.
And as we do that, we need to understand that while this soft tissues descend, they also change the angle. So it means the descent of the soft tissues is associated with the change of the angle. Now, if we use a 27 gauge needle and inject into those respective areas, either above the zygomatic cutaneous ligament here, in this respective area, or we inject right immediately below that ligament, as Ricky did here when she injected, what happens to the orientation of the ligament is it cannot be pointing downwards anymore, because here it has support, and here this area fills the soothe in a way that these ligaments can be repositioned. And now look at this. I'm just leaving the soft tissues as they are, and they stay at 90 degrees angle. So this is how soft tissue filler material can reposition the ligaments which are attached to the bone, which do not change during the process of aging. And by stabilizing those ligaments or repositioning the ligaments, the entire soft tissues can reposition. And this is why with filler material, especially with the rheology that Ricky utilized in her product, the soft tissues can be repositioned and a lifting effect or a facial soft tissue repositioning effect can be obtained. And this is just because of the underlying anatomy. I hope that everybody was able to see this demonstration with the orientation of the ligaments.
Thank you, Sebastian. Thank you, Ricky. Unfortunately, time passes very quickly. And so I would like, if you agree, to pass to the lower face. And we start as we did before. First, anatomy dissection, anatomical dissection, and then immediately after, we will see the injections done by Ricky, and we will appreciate the different techniques.
So if we move now into the lower face, it is important to understand that the lower face is a little bit of a different area. In the lower face, we have a lateral lower face, and I think we can go to the overview that you can appreciate here. And here in the lower face, we do have an area that is separating the lateral lower face from the medial lower face. And this area corresponds exactly, of course, to the course of the line of ligaments, which you can appreciate here. So this is the course of the line of ligaments, and it separates, of course, the lower face into lateral and medial. In the lateral aspects, the layers of the face are arranged in parallel. And I'm showing you this relationship here as I'm reflecting the skin and the superficial fatty layer. And this exposes here the location of the platysma. And the platysma, I dissected here the platysma to expose the masseter muscle and the important neurovascular structures, but the platysma covers the entire area here, which I incised to expose the deeper layers. But the platysma, as it covers the entire area, has some attachments to the bone. For instance, here at the mandibular ligament. Posterior to the mandibular ligament in this area here, the platysma cannot be attached to the bone because there are these two structures being in direct contact with the bone, which is the facial artery here and the facial vein here. And because these two structures cross the mandible, the platysma can glide, and this is why we have in this area here, we have the jowls. But if we move medially, and this is an important aspect, this arrangement changes because medially, the muscles of facial expression, like we can see here for the DAO and for the DLI, these muscles of facial expression are directly connected to the subcutaneous fat and to the skin. And because they are connected with each other, they form a tight area of adhesions, and this sometimes can impose, especially during the process of aging, as depression. We call this the pre-jowl sulcus. Well, it's called pre-jowl sulcus because here we have the jowls, and here we have the depression, so it's called the pre-jowl sulcus. And this is exactly this area here. In terms of which is the most correct plane, of course, it's the superficial plane. Why? Because the arteries, like the facial artery here, or the inferior labial artery here, they travel in a deep plane. And this is why when Ricky will perform her injection technique, you will see that she will stay majorly in the subdermal plane superficially to avoid the pathways of these arteries here, and especially in the lower face. So this was just a quick demonstration of the lower face aspect, because in the interest of time, I think I really want to see how Ricky addresses this region.
And I am also interested in this. Ricky, back to you.
Yes, I have to say this is one of my favorite areas to treat because patients are very unaware of what difference we can make to this area. And this is a very good patient to show actually the volume loss. And that can give a very aged appearance and almost like a bitter appearance, a sad appearance to the face. So what I'm aiming at here, so I made an entry point about 0.5 centimeter to 1 centimeter lateral from the mouth corner. And I actually want to fill up this whole volume loss, this whole shadow that forms from the mesomental sulcus and then the prejowl sulcus to take away that sad appearance and also give support to the mouth corner. So we're addressing the whole volume loss in this region. I'm using art filler lips. I love this product for this area. I've treated so many patients, especially patients over 40 with this typical volume loss, 40, 50, and even older patients. And art filler lips is a very nice product because it's a very robust product, but it's not as thick as volume. So very moldable and really beautiful to treat the perioral region. So I'm in the superficial plane because Sebastian always scares us with those really very bright red structures that we don't want to be inside. So in the superficial plane, going
I'm very
towards
sorry,
the
Ricky.
medial part, yes, they're very beautiful, but they're very scary. So we're going right
I'm
to
really
the
sorry
medial
for
part.
that.
It can be. This can be quite sensitive. The patient is being a very good patient. I think she's already seen half of the face, so she's very relaxed now. But usually they jump her a little bit around as you get to the most medial part. And you can actually even take it down. She's got a very beautiful chin, but you can even go down to the chin, but she doesn't need any chin enhancement. So I'm doing the mesomental fold and making sure I'm getting rid of this shadow that forms with the bony resorption and loss of alveolar height that we see typically in females, and especially with loss of teeth. If they've had a lot of dental work done, it actually becomes worse. So really enhancing this whole area, and then very important, don't enhance the jowl fat pad. So we always want to be medial, the pre-jowl sulcus, and never into the jowl fat pad. So enhancing the pre-jowl sulcus here, as we can see, superficial, but very soft and gentle movements. I'm using a 23 gauge blunt tip device, but still respecting, especially if you're getting a much older patients, you often see, even with blunt tip devices, that you get bruising in this region. The perioral region is very prone to bruising. So never promise a patient that you're not going to bruise them. And this entry point, you can even reach a little bit nasolabial if you wanted to. I don't know if there's any questions on this.
Sebastian, your opinion on the level of injection? You totally agree, I see.
I do agree, of course, but and I'm really sorry that these arteries look so red, but my team here does a fantastic job with the latex injections, and this is why everything looks so bright and red. But it's important also to understand, if you look at this one, you see so many red dots here all around this area, and even in the subcutaneous plane, you can see those red dots, and all of them actually indicate that there are some vessels. And this is why when we perform this technique, we always need to tell the patient, in this area, especially when we perform subcision with a cannula, we will have some bruising. The bruising, of course, will disappear and everything will be nice and smooth as it was before. But it's really important, as Ricky said, even during the other transmissions, it's always so important to have patient communication. They need to understand that it might cause to some of these instances. And in terms of the superficial plane, yes, of course, we want to be in a superficial plane because the depression that is caused in this respective area is also because the muscles insert into the skin. And you can see that here, how tightly adherent the muscle fibers are to the superficial plane. You almost cannot distinguish where is muscle and where is skin. You can almost not distinguish between these two areas. And the reason is they're so tightly adherent. It's really like coming together with each other, really almost all like this. And when they do so, you need to detach them to apply product in between, and then you can increase the volume between them because you perform with the blunt tip device. You perform with this blunt tip device a little bit of subcision, create the space, and you refill that space, of course, with the filler.
I have a question for Ricky arrived now. So Ricky, is it preferable skip jaws when injecting mandible or include it in terms of results and safety? Can you explain your opinion?
You asking if I should skip the jowls? I think we never fill the jowls, but I assume what they're asking is, should we skip the pre-jowl sulcus?
Yeah.
And it really depends on the patient. Sometimes by doing the zygomatic and temporal, we get already a lot of lifting and it doesn't need to be addressed. But the older the patients get, the more they have volume loss and bone resorption. And then we often have to add that just to make sure that we also address this, that we don't still have a shadow. Because we can lift dramatically, but you can only lift so much. And sometimes you need to just also volumize to get rid of that shadow. And I think, I really hope you can see it on screen. For me, it looks very, very good what we've achieved on this patient. We can really see that she's got a very beautiful jawline now, not that indentation, the melomental fold, because that shadow really makes, like I said, make the patient look very sad actually, and gives a bitter appearance. And then obviously the lateral and the superior lifting has also addressed it already. So can you see it nicely on the screen there?
Very, very nice, the result. And really you see the difference between the right and the left side. That is very impressive. Also nasolabial folds. Sebastian, your opinion?
I think it's really nice to see on the patient how the different sides look like, and especially when you look at how Ricky treated this, you can see a very nice OG curve. You can see a very nice OG curve, especially in this 45-degree angle between the left and the right side, to be precise, between the treated and the untreated side. And you can see the difference between that side. Look at this beautiful OG curve. You can see that beautifully on this side. And if the patient, yes, exactly there. Look how nicely the cheeks are, how nicely the contour is. And if we look now to the other side, it's substantially more flatter. Just look at this one. The patient is still beautiful. I mean, this is a beautiful patient, but you can see how flat the midface is and how flat the OG curve is. This is really important to understand what the techniques have done to the face with adding a little bit of volume. And if you look at this one, and if you look straight into the camera with the patient, I think you can appreciate that one side of the face, especially the treated side, looks a little bit slimmer than the contralateral side. If the patient could look a little bit more towards the treated side, so a little bit move the face back and forth, you can see that the treated side looks a little bit slimmer than the untreated side. And the reason is, it's just repositioned. The soft tissues have been just repositioned towards where they originally belong. And this can be done, of course, with the applied product and with the great skills that Ricky demonstrated today.
Thank you. Thank you. I have a question for you coming from the audience. What are the facial connections, if there are, between upper and mid and lower face, or if there is a total connection from the upper to the lower face?
Yeah, this is a very great question from the audience. And the fascial connection that covers the entire face, number one, is of course the skin. But we lose the elasticity over time, so this fascial connection becomes a little bit more loose. The other fascial connection is of course the layer number 3, which we talked about, frontalis muscle, orbicularis, SMAS, and platysma. All of them are as well connected. But if we think about that, these connections are discontinuous in the medial aspect of the face, because the nasolabial fold, there everything stops. All of the soft tissue layers, they stop at the nasolabial fold because all of them are connected to the skin. And this is not an age-related feature. Even babies have nasolabial folds. It's normal because this is normal anatomy. There's no variation in this. Everybody has it. And when all of the fascial layers are adherent to the skin, they of course stop the soft tissues that are located above. So it means in the midface. But with the process of facial aging, all of these soft tissues want to descend following the effects of gravity. And they all accumulated above the nasolabial fold or lateral to the marionette line. And this is where we have the presence of jowls, of the marionette line itself, and of the nasolabial fold. So all of this is really just because this is the anatomy. Understanding facial aging is understanding functional anatomy.
Ricky, can you please summarize finally how many ml, and then I have another question, but how many ml did you use exactly in this phase, I guess mid phase, and then you will use in the others, or you preview to use a little bit less in the other side? Which is your final number of ml?
Okay, so starting from the top, I used 0.5 milliliters of art filler fine lines. I'm going to use exactly the same on the other side to also fan the whole area. Although this area is a bad area because this side that the eye was hanging, I still want to address all the wrinkles this side, so I'm going to use 0.5 mil there. For the temporal lifting, I used art filler volume 1.2 milliliter in a bolus, which I will definitely repeat on the other side to make sure she gets a very good lifting technique. Then for the mid-face, I used 0.8 milliliters in total, about 0.5 and just under 0.4 that I injected for the medial part, which I think was sufficient. I haven't really decided what I'm going to do on the other side. I'm going to have a look now if we're going to do the same, but you definitely have to look and decide whether you're going to do it symmetrically or maybe add a little bit on the other side. And then for the lower face, so what I used here was art filler lips. I used the art filler lips, I used 0.5 milliliter often that I fan in this region, and then sometimes you can do it to the nasolabial. If they have a lot of volume loss media in the meliomental fold, as this patient, then I tend to use a whole vial of the art filler lips like I did for her, to address 0.5 for the meliomental fold and 0.5 for this pre-jowl sulcus. And this area I want to really stress, be careful to underestimate the amount of milliliters that you need to take away the shadow, because often you need one vial per side with the volume loss on this area.
Thank you. Another question, we have still 5 minutes to close. You didn't inject, in this case, the jawline because you didn't have the needing to inject, probably also for the upper face injections. But would you inject the jawline that is perfect? Do you prefer the superficial or the deep injection? And what about the angle of the mandible, Ricky? And then I would like to know what Sebastian thinks anatomically.
Yes, so my technique for the jawline is superficial. I usually start from a mandibular angle and then superficially to enhance it. Again, stay away from the jowl fact pad. So mostly this area, and often I fan it a little bit upwards. I always talk about the boomerang that I make it to get a nice angle. But as we can see, this patient has got such a beautiful jawline, maybe because of the magic that we've already done at the top, that it looks so much better, but she really didn't need it. And that's why I decided to move rather to the pre-jowl sulcus and meliomental fold. That's the one that needed to be addressed. So Sebastian will explain to us the levels and why I choose the superficial plane.
Yeah, Ricky, I mean, I'm very familiar now with your wonderful injection technique so far. And the plane of injections for this area is, of course, the subdermal plane, which means superficial to the platysma. In this instance, the platysma has been rolled down, but the area where to inject would be on top of the platysma, as you can appreciate here. And there are different ways to address this area. One dermal access point can be performed here posteriorly from the mandibular angle, and then the cannula can be advanced anteriorly. In this way, the entire jawline can be covered. And the advantage of this one is having an access point at the mandibular angle. The cannula can be retracted and can be rotated towards more superficially, and then stayed in the same dermal access point, and then can be advanced towards cranial, because this allows you to recreate a very nice mandibular angle and a ramus of the mandible. So that means it would be a thread located along this area here, and then another one located around this area. And this creates a very nice shape of the ramus and of the jawline of the mandible. The other aspect, and I think most of you can perform this as well, is the aspect that the mandibular angle can be targeted with a needle. Target this area with a needle applies and allows for the product application deep in contact with the bone. But it's important to understand, when you perform this injection, you need to feel bone and to apply then product into that respective area. You can see this here, I'm applying now product. You can see how the product and how the area is increasing in volume. You can see that here very nicely. But it is important to understand, and this is really crucial, if you don't feel bone, you don't inject. Because if you don't feel bone, you could be somewhere in this area, and in this area, you can see what is waiting for you deep down there, because deep down there, there is this vessel here. And I think every one of you knows that this here is the external carotid artery, which is located right here. So it means if you don't feel bone, you don't inject, because otherwise you could end up in this artery, and you for surely do not want to apply product into these huge vessels here. You can see that they're massive, located in this area. So this is why either staying superficial with a cannula or in contact with the bone with a needle. But if you don't feel bone, well, then you don't inject.
Wonderful. Thank you so much. So to conclude, I asked you before starting, which is the best, who is the best indication for facelift with art fillers? And so I would like, Ricky, that you summarize your idea of best indication, like this lady, I guess.
Yes, for me, a good candidate is typically a patient that is not too full in the face and not already laterally full, because sometimes you get patients with a very wide face, a very round face, and then it is difficult to add volume and make it more laterally wide to get further lifting. So those would not be the ideal candidates. So a thin skin is also much better to get a good result. A very oval type of a narrow face can work. I'm not saying I don't treat round faces, because you can actually do quite magic also on round faces with lifting, but then I would stay away totally from the lower part and try to get again a V effect and zygomatic and temporal lifting to give them that slimming of the face, because a lot of those patients want that slimming effect. So I think a lot of patients are good candidates for lifting, but it's by deciding what do you want to do with the shape of the face also, whether you want more a V effect or do you want to enhance laterally to give them more lifting, because they've got a very narrow face. So it's not as easy as one patient, but more like where are you going to decide to place it. I hope it's not too confusing the way I answered it, but it's a bit of art, a science, pharmacology, anatomy, everything together to get to the right patient.
Sebastian.
I think from the anatomical perspective, it's really crucial to apply certain principles when treating the patients, because at the end of the day, it's not about anatomy, it's about the clinical outcome. And the clinical outcome is improved when the anatomy is in some parts respected. And for this, we just need to apply some principles, like the upper face first. This starts basically when you do the treatment algorithm, when you plan the patient. Where do you start? Of course, you don't start with the lower face. You start with the upper face or with the mid face, and then move your way downwards. The other aspect is lateral face first. Of course, you don't start in the medial face. You start first in the lateral face, because this allows you to reposition the tissues, to lift the tissues, and to precondition the medial face. And then, of course, when you go to lower face, you also need to understand what are the outcomes that you want to do. Do you want to be superficial? Do you want to be deep? It's always important that you understand what is the clinical outcome and how do you get there. And getting there, this is where anatomy can guide you and where anatomy can be a guide and a good advisor how to best achieve your individualized, predictable, and of course, safe outcome.
And can I remember that also the man can be a very good candidate clinically. I have in my clinic many men coming, and also with some little changes, we can also masculinize the man in a very good way. Do you agree with me, Ricky?
Yes, definitely. It really works well on male patients. If they're very worried about the temporal lifting and the bolus, you can tell them maybe before to grow the hair slightly more on that area, but it really gives a very nice lifting effect. And then with men, always we have to think mandibular width because they like that really strong square face that makes look like they had a good workout. So we really go more for angles there and not too much rounding of curve as with females, but they're very good candidates for the lateral lifting of the face.
How long? I have really the questions arriving now. I would like to have before. How long does it last, the temporal lift? From Theodora. Thank you, Theodora. Ricky.
So I recommend to my patients every year, but we know also from the studies that odd filler volume can last 18 months, and I've seen even longer in my clinic. I try to always get my patients not to wait till the product is totally gone, but after 12 months to do then a touch-up treatment. But I've seen a lot of times, especially with arch filler volume, the rheology really allows it that after a year, you can actually still feel the product. And even now, I have an ultrasound in practice to see that you can actually still see the product. But in general, you want your patients to come back every year so that you can reevaluate if they need the product again.
Can I remind all the attendees connected, that we have a scientific paper that say that results with our filler fine lines are up to 18 months. So maybe we have to still discover exactly how long it will last. So thank you so much. Unfortunately, our time expired. I wanted to thank you all, Sebastian. Thank you, Ricky. I wanted to thank, of course, Fillmed team, Natalia Sukmanskaya, that organized this wonderful meeting, and also all the technical team that allowed us to have a really wonderful technical and wonderful meeting also this evening. Thank you so much. I remember you all that you can push the button for the certificate, and if you want to learn more, you have always our e-academy that has a lot of material where you can learn much more. Thank you again to all, and see you soon in maybe a possible next meeting. Ciao.